I want this to be as interactive as possible. Um, Circumstances doesn't allow it to be as much, but we're going to try our best to just make it as interactive and as much of a good learning environment as we can possibly do. So I'm going to start with the first case study. Jen is a 55-year-old female brought into your clinic by her husband with difficulty with speech. According to the couple, Jen has been forgetting the name of familiar objects, often gets stuck during a conversation. Sometimes she can get the words out after pausing and making extra effort, but most occasions she gets frustrated and shuts down. She explains that she knows what she wants to say and she understands everything that is being said to her. She just can't seem to find the words to answer sometimes. Okay, so in your video, I went over lobes of the brain, and we broke down for you which lobe controls what. Kind of also broke down for you where different centers in the brain that controls integral functions are located. Now, Jen is having difficulty with speech. And if you read the scenario, you'll see that she's having difficulty with speech production. She is not necessarily having difficulty with understanding, she's having difficulty with production. Now, I know in my video I say my Broca's area is firing at 100,000 times per minute. Your Wernicke's area is firing at 100,000 times per minute. If you're listening and paying attention to me, Broca's area, it's located in your frontal lobe. And it depends on if you are left-handed or right-handed. Most, or actually all right-handed people are left brain dominant. Now, there's a minute percentage of the population, left-handed people, that are right brain dominant. And when we say right and left brain dominant, that depends on where the speech center is located, because that's how you really deduce which part of the brain is dominant and which is not. You deduce it by your speech center. Your speech center is always located in your dominant hemisphere. And for most of us, that is our right hemisphere, whether you're left-handed or right-handed. There's a minute percentage of the population that has a dominant right hemisphere. And those people are left-handed, and it's about maybe 10% of left-handed people have a dominant right hemisphere. Only that amount. The rest of them have a dominant left hemisphere. Now, Jen, we want to ask questions like, is she left-handed or is she right-handed? We also want to ask questions like, okay, when did this start? That is very important, especially because Jen is coming in with speech difficulty. Did it start yesterday? Did it start today? Is it something that's pretty progressive? Because that would kind of get us into the idea of starting to think of what's going on with Jen. Is Jen having a stroke? Does Jen have a brain tumor? Does Jen have something that's actually affecting that part of the lobe that's been slow and progressive? Or is it an acute onset? This is what we need to figure out so we know exactly how to deal with Jen, okay? So she's having difficulty with speech production. With speech production, we know that it is Broca's speech that's affected. Broca's speech is your expressive speech. It's your motor speech, okay? And your motor center is in your frontal lobe, okay? Your sensory center is in your parietal temporal lobe, which is your Wernicke's. So you have Broca's and Wernicke's. Broca's expressive, Wernicke's receptive, okay? Understanding. So from her description, she's having difficulty expressing, not understanding. So when we ask which area of the brain is being affected, it's probably frontal. And if she's right-handed, it's definitely left frontal. Okay.
Dr. Morton, I'm sorry to bother you, but there's still some people without their mics muted and there's a lot of background noise. Can you guys please make sure you mute yourselves? Thanks so much. Sorry, go ahead.
No worries. Let me pick up where I was. I remember where that was. Anyways, so again,
Frontal, I think you were talking about the frontal lobe.
I got it. So your motor speech again, frontal lobe, okay? Your receptive or your understanding of speech your receptive speech is located in your temporal lobe, which is your wernical speech, okay? So the questions we want to ask, when did this start? Okay, is this slow and progressive or is this an acute onset? Okay, we want to ask, is she right-handed or left-handed? Because then we're trying to deduce which part of the brain is being affected. Okay, and these will help us with our differential diagnosis in the future when we're doing. But now we have to figure out how we're going to assess her. Okay, so we're going to do a history with the questions. What are the most important questions for you to ask the couple at this time? Again, did it just start today or has it been progressive? And if they tell you this is an acute onset, you want to know the exact time of onset. That is very important in the history. Okay. What are the pertinent questions? Okay, well, they tell you that this started like 3 days ago. You want to know, okay, is she a cancer patient? Does she have any malignancies? Because then you're thinking metastasis. How do you work that out? Okay. What are the initial tests that you would order for this patient? Well, if they tell you it's an acute onset, or even they tell you that it's been going on for a while, the fastest test that you can possibly do in this patient is a CT scan of the brain. CT looks good for blood, okay, and it will show you abnormalities. It doesn't look well at tissue. So if there's a stroke or if there's a brain tumor, you're going to have to order an MRI, which is more sensitive with tissue. However, initially, when someone comes in like this, you always want to rule out blood. Okay, so this is where you're going to say, well, I'm going to get a CT of the brain. Other pertinent questions: did she have any head trauma? Okay, a head trauma could actually give you a intraparenchymal hemorrhage, a subdural hematoma, epidural hematoma, and all of these can give you an acute change in neurological status. So you have to find out from her if she had any head trauma. Was she in a car accident recently? Does she have any history of malignancies? Okay, and you also want to know vascular risk factors. Is it, if there was an acute onset, it could be a TIA. It could resolve in a little short time after that. So you want to know, does she have hypertension? Does she have diabetes? Any vascular risk factors that can put her at risk for a stroke. Okay, again, the initial test we want to do, we always want to rule out blood first, because that is an acute phenomenon that she may need surgery. So you want to make sure that there's no blood. So you're going to order a stat CT of the brain to check this out, okay? If your diagnostic test shows stroke or tumor, what part of the brain would you say is affected and why? We just went through talking about where Broca's area is. We said that this is expressive speech, and Broca's area is located in the frontal lobe. And for most people, if she's right-handed, it's left. If she's left-handed, then it's hard to tell. We'd have to look at other symptoms. So if she's left-handed and she has weakness on the right side of the body, then you're going, okay, well, if weakness is on the right side, then it's the left brain. So she's having speech difficulty and right-sided weakness, we know it's the left brain. But if she's having speech difficulty and left-sided weakness, then you're going, okay, so if you're having speech difficulty and left-sided weakness, if your left side is weak, then it's your right side of the brain that's being affected. So therefore, her speech center may be in her right brain. And that is how you're going to tell if she's left brain dominant versus right brain dominant. Now, if by any chance that she has no other symptoms, you have to wait for the imaging. Okay? Doing a neurological assessment, it is so important that you understand the basics of your anatomy, because if you don't, you can misdiagnose someone. If you do, it's easy for you to start saying, okay, where in the brain, what's going on here, and you can actually deduce and you can actually come up with pathology for what's going on with the patient without even scanning them, okay? So you really have to have a basic understanding. When you're dealing with neurologically ill patients, you should have a basic understanding of neuroanatomy. It actually helps, okay? Do you have enough information to formulate a diagnosis? No, you really don't, okay? Other things too that you want to consider. Has she had fevers? Okay. Has she had issues with nausea, vomiting? Because she's had fevers, then she could have an infection. Can definitely have a brain abscess. Does she have a sinusitis? Does she have an otitis media? I always tell students all of this is connected. Okay? So if she had a bad sinusitis and she comes in now with speech difficulty, or she comes in now with headaches, she can definitely have an abscess in her brain. That's on that side of the brain. Okay. Does anybody have any questions on case 1?
That's why every 6 months you're having this problem. So until
Anybody?
let me see it.
We're hearing background noises still, guys.
He did not.
All right.
Dr. Morton, everyone's giving some good ideas here in the chat box about different symptoms and stuff. Do you want me to tell you or just?
Yeah, please. Tell the rest of the class. I can't see it.
Okay, you can't see. Okay, yeah, no, they should be able to. If you guys check out the chat, that's people are putting ideas. Actually, a question is, would abscess be shown on CT?
Actually, the abscess will not be shown on CT. It will show that there's an area of hypodensity, which could be a lot of different things. It could be a stroke. It could be an abscess. It could be a tumor. It is very hard to tell. Okay, so I can't tell you for sure that an abscess you can't say it's not an abscess. All you can say is that there's an area of hypodensity that you need to evaluate further. Remember, CT, great to look at blood, great to look at bone, not so great to look at tissue. So if there's an acute tissue, something going on, you will need an MRI of the brain. So that is where you're going to move to next. Any other questions I missed, Laura?
I don't see.
Contrast would make a difference.
Oh, there it is. Yeah.
Contrast can highlight the area, and it can show up as a stroke. It can show up as a tumor with contrast. The problem with iodine, with CT contrast, it's iodine, and iodine is very nephrotoxic. So instead of putting them through that, it's better to do an MRI. An MRI actually is perfect to look at brain, at tissue. An ultrasound will not show an abscess. Okay. We don't really use ultrasounds on adults, especially in the brain. We use them on the pediatric neonatal population, but not so much adults. Anyone else? Did I miss anything else, Laura?
I don't see anything else. I think that's it.
I forgot about the brain part. What is it? Oh, no worries. No worries. Okay, let me go back. I have to hide the chat box again because I can't see the rest of the scenario. Okay. So case number 2. John is a 57-year-old right-handed male brought into the emergency room via emergency medical services for an acute onset of weakness and sensory loss over the left side of his body. Immediately, you're thinking the left side of his body is controlled by the right side of the brain. Okay? So you're knowing at this point something is going on in his right brain. He's able to move the right side without difficulty, but denies sensational pain or temperature on the left. Additionally, when presented with his own left hand, he denies that it is his. He will not respond to you unless you're standing on his right side. You suspect that he had a stroke, which is confirmed on imaging. Which area of the brain would likely cause John's symptoms? Okay, so when we did the neuroanatomy on your video, we talked about the parietal lobe. And the parietal lobe is our sensory lobe. So it actually tells us where we are in space and time. It's good for sensory integration. So when you have someone who is having sensory loss, okay, you, especially when they have pain and temperature, they can't discern pain and temperature sensations, you want to start thinking parietal lobe. Because remember, all the sensory input from the body goes into the brain, goes up through the spinal cord, in through the thalamus, and then to the parietal lobe for sensory integration. The back of the frontal lobe is the motor cortex. The front of the parietal lobe is the sensory cortex. Okay, so motor cortex, frontal, sensory cortex, parietal. The parietal lobe is more like a sensory integration lobe. Okay, so he's having difficulty with pain and temperature sensation on the left side of his body. And he has something that we call, when we put his hand in front of his face, he is unable to identify it. That's actually called neglect. Okay. When he is neglecting one side of his body, you're going, okay, he cannot discern his own hand. When someone's doing that, you want to think about right parietal. Okay. Right parietal is the lobe that's actually giving you those symptoms. Okay. There's another word for it, and why is it not coming to me at this moment in time? But it'll come to me in a few minutes. When you neglect, you can't identify your own body in space and time. And for some strange reason, I can't remember the word right now, but it'll come to me in a few minutes, and I'll tell you. So he's not able to identify pain and temperature on the left side of his body. Anytime you see that, where you can't discern the left side of your body, they can't tell where they are in space and time, think right parietal. Okay, think that something is going on in their right parietal lobe. And these patients are at high risk for hurting themselves. One, because they don't realize that the left side of their body doesn't work. They have no perception of it. So they will try to get up, and then that side of the body doesn't work, and they would fall and hurt themselves. So one of the main things that you want to monitor for these patients is safety. They can really do some real bad damage. And actually, that was a question on one of my neuro boards. They always ask that question. Right parietal injury, patients are at high risk for danger of hurting themselves because of the fact that they do not understand what's going on with that left side of the body. Okay. All right. Any questions there, guys?
Someone asked about visual field agnosia.
No. Agnosia is, remember, your vision is in your occipital lobe. Okay. So you're not gonna have any visual issues from your parietal lobe. Okay. Agnosia is the ability to, let's say I have this, I don't know if you can see it, this cap in my hand. Agnosia is the ability to recognize common objects. I see somebody is asking about agnosia there. That's why I'm saying that. If I put something in your hand, without you looking at it, you're supposed to be able to identify it. Okay? Your inability to do that is called agnosia. So nausea is the ability to recognize familiar objects. If I put a key in your hand, if I put a pencil in your hand, you're supposed to be able to take that key or that pencil and recognize what it is. The inability to do that is agnosia. And yes, that comes from your right parietal also. Praxia. Praxia is the ability to perform known tasks or learned tasks. If you are unable to do that, you become apraxic. Okay. And again, that also comes, praxia is more frontal lobe. Nausea is your parietal lobe. Okay.
We have a couple questions too. Autopagnosia and prosopagnosia. Sorry, I didn't have a hard time with
Autopagnosia is really that writing in the arm. If I write something in your hand, you should be able to identify it. The protoprognosia, I don't know what that is. I've never seen that before. So you can identify that. If you can define that, that would be great. Okay. We have agraphia, agraphia. Agraphia is basically, if I write the letter E in your arm or your hand, you should be able to identify it without looking at it. Okay. Agraphia is the ability to do that. So that's another one. What else?
The prosopagnosia is inability to recognize familiar faces.
Oh yeah. Photoprognosia, she means.
That's what I'm guessing.
How you say it? Come back down. I can't see that question. Your agnosias, again, you have visual, you have auditory agnosia, you have visual agnosia, you have sensory agnosia. Your visual agnosia is basically your occipital lobe not being able to interpret what it is. Your parietal agnosia is basically three. So those are the different types of agnosias. Okay.
Someone asked, what is the term of the neglect?
I can't remember. Is there hemibody neglect? There is another word for when you can't recognize it, but I can't remember what that word is. Hemianopsia comes from the parietal, the occipital lobe. Extinction. Oh, Jennifer, yes, that's what it is. I could not remember that word. It's extinction. So when you're not able to recognize one side of your body, it's called extinction. All right. And for some strange reason, I couldn't remember extinction.
Guys, someone still has their mic on and we can hear you turning your pages. I think it's Yerazette, not to call you out, but I can hear you turning the pages. Can you just mic mute your mic, please? Thanks.
Is everybody good? All right, closing that. All right. Jane is a 53-year-old woman, presents with complaints of vision loss after an auto accident, where she pulled out in front of her car approaching from the left side that she claims she never saw. On complete visual field exam, you find that the woman has a left homogeneous hemianopsia. You perform an MRI and you find a stroke affecting part of her visual field. Based on her visual field defect, which of the following is the most likely location of her stroke? Now, when we talked about the occipital, we had the right occipital lobe and the left occipital lobe. And in your HENT lecture, you should have gone over a little bit of your visual fields and what your visual fields are and which conditions will give you which visual field neglect or which visual field would be affected by what. So remember that you have your right visual field is completely on the right. It's one visual field. So it's not one eye. When you're doing your visual fields, you're doing confrontation. You're checking the visual fields on the right side and you're checking the visual fields on the left side, okay? So your right visual fields is half of this eye and half of the other eye, everything to the right. The left visual field is half of this eye and half of this eye, everything towards the left. A homogeneous hemianopsia means that that entire visual field is gone. We have also quadranopsias, which means a quarter of that visual field is gone. And we have bitemporal hemianopsia, which means that the outer visual fields on the temporal sides are gone. Now, when we discussed HENT, we talked about pituitary adenomas. Pituitary adenomas, because the pituitary gland sits in your cellotertica, which sits right below the optic chiasm. So when that pituitary adenoma grows, it actually compresses the optic chiasm. When it compresses the optic chiasm, you get that bitemporal hemianopsia. If someone has bitemporal hemianopsia, you're not thinking stroke. Not that it can't be, but usually it's not. You're thinking bitemporal hemianopsia, that's probably not a stroke. That's probably a pituitary adenoma. Homogeneous hemianopsia means that the entire visual field on the right or the entire visual field on the left is gone. And that usually indicates that there's something in the occipital lobe. So whether there's a tumor, whether there's an abscess, whether there's a stroke, it is in the occipital lobe. If I have a left homogeneous hemianopsia, I have a lesion in my right occipital lobe. If I have a right homogeneous hemianopsia, I have a lesion in my left occipital lobe, okay? So when you're looking at homogeneous hemianopsia, it depends on where it is. And usually, if that's happening, it's a lesion of the occipital lobe, okay? Now we have right occipital lobe here as one of the answer choices. You have a car approaching from the left, and usually this is how people know that they've lost a visual field, because they'll tell you that there's no way, I didn't even see that car coming. They had no perception of that car coming, and that car comes and slams onto them, okay? So if that person was approaching from the left and they didn't see the car, that means that they have a left visual field cut, or left visual field neglect, or a left homogeneous hemianopsia. Now, strokes can give you quadranopsias also. It could be half of the visual field that's gone, or a tumor, depending on where in the occipital lobe it sits. So it can be a left homogeneous hemianopsia, a right homogeneous hemianopsia, or quadranopsia. Those are associated with strokes or tumors. But if we're thinking about a bitemporal hemianopsia, we're thinking something in the optic chiasm, or some kind of issue with the optic chiasm. So you have a tumor growing, or a macroadenoma from the pituitary gland, or you can actually have a hemorrhagic, a hemorrhage into the pituitary gland that can actually give you issues like that. So you want to think about those things. If it's a bitemporal, they've lost visual fields on both sides of the temporal areas, then you're thinking, okay, this is something with the pituitary gland. If they've lost half of their visual fields, you're thinking occipital lobe. Quadranopsias sometimes can be your occipital lobe stroke, or depending on what's going on, it could be that they have a macroadenoma that's only pressing on one side, and it's actually cutting off some visual on one side, and that's why you're seeing a quadranopsia. But textbook, a bitemporal hemianopsia, pituitary, homogeneous hemianopsia, or quadranopsia, you're thinking occipital lobe, okay?
Is this condition reversible?
Which condition?
The
homogeneous hemianopsia?
Yes, I'm believing that's it.
If the stroke, remember, when we talked about neuroanatomy, when you lose neurons, when neurons die, they do not come back alive, okay? Most of the times, there's a little bit of swelling after a stroke. So when that swelling reduces, then some of the vision may come back. But a lot of times people have to live with these. There's a lot of therapies that they do, occupational therapy, where they teach them to drive with these neglects. It is very difficult. A lot of these people have to actually get these types of training before their license can be reissued, okay? Because if they have it documented in a medical record that they have a homogeneous hemianopsia and they did not go through proper channels, and then they get into another accident, they can be held liable, okay? So usually they go to rehab, they work with the occupational therapist. In Baptist rehab, or in the rehab center, they actually have simulated driving, that they put the patients through these simulated tests to actually give them back their license if they can pass. But most of the times, if it's a stroke, usually they do not come back. It may improve, but to regain it completely back, sometimes that doesn't happen. Any other questions? And you guys remember how to do your confrontation testing. I'm gonna use my niece as a guinea pig so that I can do the demonstration on her. Julianne, she's supposed to be close. Come on, hurry. Sit right there. Hi guys, say thanks, Julie, for being my guinea pig. All right. So when you're doing your confrontation test, remember you're standing in front of the patient and you're going to check the visual fields in both visual fields. Now, grossly, you do not have to tell the patient to cover their eyes. Grossly, you can do it without them covering. So you're going to stand a distance away and remember that you're checking your visual fields against theirs. So if you're not seeing your hand, they can't see your hand. If you're asking them to count fingers and you can't see the fingers, then they won't be able to see it either. So
Dr.
you'll have
Martin,
to make
can
sure
you
that
move
they're
your
in
camera
your
down a
visual
little bit?
field. I'm sorry?
Can you move your camera down a little bit? We can't see her very well. Awesome, perfect, thank you.
Here now?
We're good.
Close the
Thank you.
window. Is that better?
That's even better, perfect.
Yeah, I think
Thank
there was
you.
a light through the window. All right. So I'm standing here and I'm gonna ask her to look at my nose. Don't move your eyes, don't move your head. Just look straight at my nose and tell me how many fingers do you see. Now. 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 Now you see I'm going through both visual fields. I didn't just check one eye and that's it. I have to make sure that I check on both sides. Now, let's say I had asked Julie to do that and I noticed that when I put my hands this way, she didn't see them. Now I'm gonna say, take your left hand and cover your left eye for me. Okay? And I'm gonna do the same. And I'm gonna tell you, look straight at my nose, don't move your eyes, don't move your head. How many fingers? Now? 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 Okay, and I'm gonna have her do it on the other side, the same way. Okay, I know a lot of you do the thing where you do, tell me if you see my fingers, tell me if you see my fingers. Again, it's not resourceful if you pull your fingers all the way in front of the patient and then say, tell me if you see. So you wanna make sure that you're wiggling your fingers at a safe distance so that they can see, okay? If you're doing, tell me if you see my fingers, you wanna bring your fingers in slowly so they can identify when your fingers are there. Anybody have any questions on that? Anything, Laura?
Yeah, a couple of questions. Is there any way to have you on the big screen when we do that? And do we not cover the right eye as someone's asking?